I am very honored to introduce our first keynote speaker. Dr. Ferguson is a distinguished physician leader, health equity advocate, and community organizer who has long been dedicated to improving healthcare outcomes and advancing inclusivity in medicine. He's board certified in family medicine from the University of Utah and has practiced emergency medicine in critical access facilities throughout the country. He also has an MBA from the Eccles School of Business. Dr. Ferguson served in the U.S. Army as a battalion and brigade surgeon for 7 years in Operations Iraqi and Enduring Freedom. And he has said that one of the most impactful times of his life as a physician was in the care of his soldiers and their families abroad. Dr. Ferguson has consistently championed initiatives that address systemic healthcare disparities. In 2021, he established the Black Physicians of Utah to improve healthcare outcomes for Black and underrepresented Utahns by increasing the number of Black physicians in the state and through multiple health education initiatives. Under his leadership, BPOU has launched cornerstone initiatives such as the Medicine Immersion Day, which connects Black physicians and medical trainees with young Black and marginalized students to inspire future healthcare professionals. He also spearheads the BPOU Clinical Research Internship, which offers Black undergraduates and rising freshmen immersive opportunities to engage in clinical research. He most recently helped to launch BPOU's Mental Health Advocacy Branch, which focuses on informing and addressing the mental health needs of Black Utahns. Dr. Ferguson also works as the Chief Medical Officer for Health Choice Utah, where he oversees clinical strategy and operations for the organization's Medicaid health plan and has been instrumental in developing programs to improve access to care for historically marginalized populations. And he's the interim CMO for University of Utah Health Plans. Dr. Ferguson is a recognized leader in combating ageism in healthcare and in promoting health equity across diverse patient populations. He's led key health education events addressing chronic conditions, including obesity, cancer, and heart disease. And in his spare time, which I can't believe he's got any, he's also completed over 40 triathlons. So please join me in welcoming him to our symposium.
All right, everybody can hear me okay? Or do I need to speak into this? This sounds okay? I like to move around a little bit. All right, well, good morning yes, it is still morning. Thank you for that lovely introduction. I'll have to give you my shorter bio next time. I was like, oh, she's got the long one. And as a slight correction, just because there's been a change, I am now the Associate CMO for University of Utah Health Plans. No longer interim, I now have a boss. So I'm no longer free reigning it. So one thing that, when I was asked to do this keynote today or a talk, I said, so do you kind of want me to just give personal experiences? Do you want me as someone that's worked in the ER and has done quite a bit of humanitarian care, some of the vestiges left over from my time as active duty in the Army as a physician, I have actively seen, and unfortunate women that, if you think there are disparities in healthcare now in our US, just think about pregnant refugee women that are getting zero prenatal care until possibly a doctor like me stumbles into their tent, checks their blood pressure, and does an ultrasound. And I have to say, more than 50% of the time, I don't have good information once I perform it. I'm actually about to go on a medical mission to Amman, Jordan, to take care of Syrian refugees in about 3 weeks. So look for photos of that on our BPOU Instagram. But anyhow, this topic really struck me because it's not discussed enough. And of course that led to me having to do a little bit more research myself because I don't know if people here, did anyone go to our Aftershock event we had 3 years ago? Okay, so some people might remember me when I had our little panel, but that was a fairly moving film. And that sort of, to me, it brought it a little bit more into mainstream through film, through art, because I think it premiered at Sundance the year before. And that really motivated me to say, wow, I knew that there were always disparities for Black women when it came to maternal health outcomes, but having been asked to speak today, I was really struck by, like, wow, it's it doesn't stop with just delivery or complication with the mother. Quite a bit continues in utero that will lead to a stillbirth. So I'm going to kind of take you a little bit through history here on what I feel are the causes, our foundations in our nation, in our system, in our institution that leads to continued problems with stillbirth. But also I'm going to lend on a little bit of a happier note because this can be a troubling and a challenging topic to discuss. So, the how and why of health inequities and stillbirth prevention in America. Bit of a mouthful there, but so much can be connected to our foundations on some of the how race is recognized in our nation, and also where you live. So, why this matters now, and please forgive me if I'm doing a little bit of repetition from the lecture that was done before. But I felt like, having it at least 2 or 3 times doesn't hurt. So in 2023, U.S. fetal mortality rate was 5.5 per thousand, and persistently higher for Black, American Indian, and Alaskan Native families, and a gap that's largely unchanged for decades. A gap that's often largely unchanged for decades are doctors that look like me, which is kind of why there's this impetus and reason for BPOU. Because for decades, since pretty much 1971, the percentage of Black male physicians have not increased in our nation, even though there's tons of programs, and my programs and what I'm doing is not so much very unique to Utah, but not across the nation. But yet we still can't seem to budge the needle. Same applies here when it comes to fetal mortality rates. So the inequity, Black pregnancy, and mind you, most of my slides I will be referring as Black, marginalized groups, or American Indian, just because I think that's the racial classification that the CDC uses in Alaskan Native. You have to understand, I represent a Black nonprofit organization. Most of my experiences will be with, and as a Black community leader, I'm hearing the voices and stories and history of Black women that have experience with maternal care. So just as a little caveat there, shouldn't be a surprise. But the inequity, twice the risk of stillbirth versus white, even after you adjust for socioeconomic, which I will go into later when we start going through a little bit of social determinants of health. But this points more to the structural and clinical drivers that I'm gonna go into here in a bit. So here's a quote that I often think of when I'm doing any lecture that addresses health inequities, and that is, the transform healthcare, we must acknowledge that trauma of systemic racism, which I will discuss at length here today, the trauma of systemic racism together to solve it. And Peggy McGuire, if you can read some of her stuff, it's great. And then also, this is something we see frequently during Black History Month, January. Sometimes this quote is taken out of context, but of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And a lot of this, you have to understand, the perspective that Dr. Martin Luther King was coming from at the time, and that's in the Jim Crow era, the Jim Crow South. In Jim Crow South, if you wanted to codify and have a perfect example of codification of racism, saying, because pretty much if you make it a law, then it's not illegal, right? So if you make racism legal, then no one's doing anything wrong, and then there's no prosecution, and you just keep widening that gap. This applied a lot to healthcare access, as I will soon go into, although briefly. That is one of the vestiges of systemic institutional racism that is still very, I wouldn't say, I don't like to use the term prevalent because we're aware of it, we're trying to stem it, but it's still very much present, stronger in some areas of our nation than others. So, the origins of health inequity in America. I think before we can get to America, we have to also go back to race. Race as a social construct, right? Because all of us, besides our phenotypic expression right now, we are all the same. Bleeding the same. We all, well, many of us, if you live long enough, will develop hypertension possibly, have impairment with your organs. We are very much the same, but it didn't start until we had the father of taxonomy, Carl Linnaeus. All right, so this is a Swedish biologist. And he didn't feel he was doing any harm at that time, but he was taxonomy. He went through and said, this is the genus and species for many of type of animal and organism on our planet. He was starting to define that. However, he defined us as Homo sapiens. And then from that being designated, I then went from, that was then taken by a French philosopher, and he then took that about 14 years later to coin the term race. All right, so I think his name was George Louis Leclerc, and he was the first time to use race as a scientific term. Okay, so just like with codification of racism that I'll go into later, a racist law, which we unfortunately, it's coming up in our modern media today, but the codification, so when we started to use the term race, which started us as just a biological term of how are we going to classify people, it went from race, from the French philosopher, and then eventually it went full steam with Blumenbach, and this is a German physiologist, and he expanded the idea on the natural variety of mankind, proposing that there are 5 different races. And then he pulled upon his Linnaeus, and you had to have descriptors if you're going to have further taxonomification of humans. So it went further into describing people, and then once you start putting this down and calling it science, it then is going to make it where? Into a textbook. And someone's going to say, and then so people that are leading institutions are going to say, well, you know why this race acts this way. It is part of their DNA. This is part of how they have been classified. See, it's been studied. Dr. Blumenbach wrote it down. Therefore, it is fact. So we get descriptions such as Native Americans, obstinate, married free, regulated by customs, Afrikaners, relaxed, crafty, negligent, governed by caprice. This is all how this was translated in the turn of the, or should I say mid to late 18th century, which also there was an unfortunate trade that was occurring during the transatlantic at that time, which made its ways to the Americas. But what I really want to emphasize here is these foundational principles on what is race, what it is to be human, made it into our leading institutions, particularly our medical textbooks, when it came to describing how one race will act upon another. It's the othering. This is the beginning of othering one race from another. And majority of this text was written by Caucasian or those of white descent, or pretty much those that were not distinguished as being of color. It is seen as the original race, therefore the most beautiful, often associated with higher intelligence. So you have this as justification for often when someone is enslaved, particularly in our history here, saying, well, this is appropriate role for them. They are different than us, othering, and it's also another term for that is dehumanizing when it came to early foundation of racism in the US. So as we go a little bit further, what are the forms of racism? Because sometimes we hear systemic a lot, but we didn't realize that there's pretty much, I'll just say 5 different types that make the one. And I will spend more time on interpersonal, structural, and institutional. Internalized, that sometimes is taught by someone. That's what you see often demonstrated widely in media. It's the ugly stuff that you see from period films in the Jim Crow South, or possibly on media today at a possible protest or rally if someone's yelling slurs. But for the most part, I will focus more, because we don't really generally see that in our healthcare place. You may hear somebody say something under their breath when a woman of color who is coming from, possibly unhoused and is pregnant and seeking care, and may have an odor of, when they come into the room because they're unable to maintain their hygiene, and then comments will be made by the staff. And if they say something such as those people, that's when we get into, that's almost a form of internalized, but that's more interpersonal because it's directed particularly at that individual, but also she's not stopping there. That means if she's feeling this way about that particular individual, it can apply to other individuals that look like her. So, but I'm going to make sure that we have healthcare examples. So, definition, so internalized racism, just as background. So that involves accepting the negative societal beliefs about one's racial group that affects one's self-worth or behavior. So patients may delay or avoid care. So this is where we start to, when you don't have trust in the healthcare system, this is where that mistrust begins. And this is why we have, how many people here have done cultural sensitivity training? Although sometimes people are like, oh, I'm just going to click through the slides. Let me go really fast because I want to get this done so my supervisor doesn't think I did. There's a reason why it's done, and this is part of the reason why. Interpersonal racism. So this you may see amongst peers, colleagues that you work with, family members. So the definition here, and it's slightly different, this involves discriminatory behavior or language between individuals that affects relationships or an interaction. So that's, sometimes we can see this as, I experience this more so as microaggressions. Someone will say, well, you did a really good keynote the other day. You speak really well for, right? Or I wasn't expecting you to do. That's a form of interpersonal racism, but we'll use a more PC term and call it a microaggression, because that person will say, well, I have nothing against black people or people that, I just like good speakers. That's all I was saying. Impact on healthcare quality. So racist behaviors like this in healthcare can reduce patient dignity, it hinders communication, and can cause treatment errors or non-compliance. Once again, breaking down trust. If people feel that you do not trust them, they do not feel like they are heard or listened to, this will continue, especially, so the biggest thing here is if you see this happening, and this is why it perpetuates, if people will see this happening and they don't do anything to correct it. And that's often what part of my call to action is. We have to share when we know something is wrong. We don't have to embarrass the person that's doing it. There's an appropriate way to give constructive feedback to say, do you realize the impact of this? We may lose this member from our practice. This person may have a poor outcome with their child because of how we made them feel. We blamed them for their possible poor outcomes that are going on with their pregnancy, right? So, and then addressing this once again comes down to cultural competency. This is actually a large part, I wouldn't say it's probably about 10% of what we do when it comes to talking to allied healthcare providers, allies, to try and address cultural competence. Because no one wakes up and says, I want to be racist today to people. But there are actions that slowly occur, especially if not corrected, these will continue. So BPOU, and along with several of my black physicians, we go around the state actually trying to give lectures to medical schools, faculty, departments, but more so those that are at chief and divisions, so that they understand, please try to stem this in your own department so it can stop. We can't be everywhere. We don't assume also that this falls onto that one person of color to correct all this and teach us how to not be racist or anti-racist in our department, right? So if you have that one Native American doc or nurse or Latinx nurse or doc or PA, it doesn't fall to them to correct your behavior. So I will sometimes switch between obstetric racial bias and racism. I wanted to work in a case here because to kind of keep us grounded, but it's still real life, it's reality today on how maternal health outcomes are impacted based on racial bias or racism. So this first case, many people will probably pick up on it here in a little bit. I'll probably ask you before I get to the photo. So, not listened to, someone where they feel their concerns were dismissed. So, after an emergency C-section, a woman developed shortness of breath and specifically requested a CT scan. So they were knowledgeable about the healthcare system and what possible complication. So this was a fairly well-educated patient that knew their body and knew something was wrong shortly after C-section, and asked for heparin due to her clot history. So she was already concerned about what? PE, right? Staff initially attributed her concerns to pain medication and ordered a leg ultrasound instead, even though they had a clot history. CT was obtained only after her insistence. Once again, self-advocacy, which we at BPOU take very seriously, wanting to convey to our patients, leading to finding multiple pulmonary emboli, anticoagulation started. Who is this person that? Very good. All right. Okay, so that is someone has the means, knew their body, knew their condition, knew their risk factors, and still was not being listened to. Imagine if it's someone without those means. So, institutional racism. This is where we can all start to have some impact or effect. It's embedded in organizational policies that lead to often unequal outcomes for racial groups. Hospitals in predominantly black neighborhoods often have less funding, outdated equipment, and staffing shortages. You can see this more prominent where there is a larger minority population in, say, a certain city. So you're thinking, you're Memphis, you're Atlanta, you're Detroit, Chicago. Cook County is an example. I think it's, is it Graney? I'm trying to remember, it's something with a G in Atlanta. They're always threatening to close it down, but it's in a predominantly black neighborhood, and it has limited funding and often able to, they often sometimes have to send someone out to an Emory or another institution that has more means. So why do they not have as much means? It's because it's based on the tax base of that everyone's lives in there that helps towards the hospital? Is it a nonprofit that people don't donate much to? Is it about they don't really have their representative doesn't lobby to actually get much funding for them? Did they not get someone to advocate for Medicaid expansion in their area? But they did on the other side of town. Mind you, it works by state. But I think you're kind of getting my point. This is when you're at a policy level that can impact an institution. So often you have unequal resources that limit access to quality health care that can lead to poor outcomes. And then we go from institution to structural. So structural, this is where we have societal systems and policies. This is where I talk about Jim Crow, what's it called? The Flexner report that came about in the turn of the 20th century that led to really significant reduction of black physicians in our nation because they closed down 4 out of the 7 medical schools, black medical schools at the time, because the hallways weren't wide enough, or they didn't feel they had sufficient surgical equipment in that particular med school for training purposes. So, redlining, that's what I kind of have here with this description. Segregated neighborhoods, limited access to quality health care. I'm sure people have seen possible movies, news stories where you pretty much, black folks in that marginalized group didn't get a choice and they just put a highway right through the neighborhood. And so there's not even a crosswalk to get to the other side. And this isn't necessarily just to the US as well. Right? This has been done in other countries where you have folks that, they shift to the other side of the river, they're on the hill now, the more flood-prone area, people can't afford to get out of, they stay there, their hospitals aren't as well funded, they don't get the best healthcare access, thus their life expectancy is lower. But some of that is a result of structural racism, and particularly because there's system or policies that have been put forth to lead to less resources for that one neighborhood. So, communities affected often leave nearby hospitals, specialists, and impacting care. And also that will lead to people like myself, we often applaud many black docs that want to move back to an area, say they came from, they were able to make it out of this, where they had social determinants of health working against them to become a physician. And if they go back, but often they will not have many doctors in that neighborhood. So someone has to take away from work time to go on the other side of the river, other side of the freeway, other side of town, just to try and get the same access to care that the people already on that other side of town had. So, more racial bias in medicine. We have another example. So, leading cause of death for maternal outcomes. So, not particularly the C-section, but postpartum hemorrhage. So, see if anyone can identify this case. So, following a routine C-section, a woman's husband repeatedly reported bloodstained urine in worsening condition. She was not taken back to the OR for roughly 10 to 12 hours after this. Surgeons later found massive internal bleeding. The patient died, prompting a federal probe and national scrutiny of how black mothers are treated. Does anyone know who this was? Who?
Kara Johnson.
Very good. So, once again, someone with means had a C-section. Doctors should know that we're taking care of her. The nurses should know, who was probably at the bedside with her, especially post-op, and the husband was advocating. Mind you, I have another example where the same thing was occurring for a close friend of mine I went to college with. she was having the same complications, but it wasn't until her white husband spoke up that actually they started to intervene, got a blood count. Oh my God, your hemoglobin's 5. She's having postpartum him. Let's take her back. But she was saying, I feel weak. Why is my pulse high? What's wrong? This doesn't feel right. I don't feel right. And from one end, and on top of that, the doctor was changing. It wasn't the person she had most of her pregnancy with. It was someone that was covering for that practice. So she went from having a black female for most of her pregnancy, but of course, babies don't tend to come on as planned. So she ended up delivering with a partner, and that partner dismissed a lot of concern in Asian male. So, structural racism in medicine. It leads to a historic lack of respect for black and brown bodies. Deeply rooted belief system about black health as less important for centuries, and an unconscious, this is the key, unconscious consideration of pain tolerance. That's that othering, right? That goes all the way back to the 1700s. So, and then this all, if you remember my little diagram there, it then all feeds into systemic, which is you have widespread racial bias that's present in institutions, leading to persistent disparities, and that will impact healthcare outcomes. So that leads to that higher maternal mortality rates among black women, also Alaskan Native and American Indian women, and the institutional effects will lead to, it influences medical education, research priorities, healthcare access. But the other thing that I really want everyone to take away is, the only way that we can really begin to try to address this is a holistic approach that includes reforming our curriculum, but we might get fined for that if we bring up race and its impact on healthcare. Diversifying workforce, BPOU, and prioritizing equity in policy. Hopefully, people on the Hill will continue to take health equity seriously in Utah, such as Senator Escamilla, right? We have our doulas now. That is now being covered. For a while, it was just out of pocket, and if you had the money to do so. That's something that I really pushed and advocated for the last 3 years. Yep, come on. What's going on here? All right. So just to kind of get us forward, a slow institutionalization of racism into our medical practice in America. So we have to understand there were separate white physicians for slave patients versus white patients. They wouldn't go to the same doctor. And it was believed that slaves' bodies were physiologically different. Our skin was thicker. We were made to work outside. We're more tolerant to pain. So thus, seen as almost that veterinary medicine was practiced, which also led to, well, we are allowed because they are subhuman or different than us, we can experiment. So I'm sure everyone knows James Marion Sims, right? We tend to think about that torturer, also known as the father of American gynecology. But many slaves he wasn't alone. So many of these physicians treated black enslaved individuals experimental subjects. And so this expanded the physician's knowledge and reputation, but led to mutilation and death. So, what links the legacy of racism to the structural and institutional aspects of racism in health today? I know I said racism a lot there, but sometimes we talk a lot about social determinants of health, but that's actually downstream from structural determinants of health, which I've alluded to right now. So, structural determinants of health, that's our legislation, our public policies, civil procedures, practices, cultural norms that shape social determinants of health, and that eventually will shape the health of individuals in the communities we serve. So the key is, when you legislate it, you put it in a textbook, create public policies, that's your redlining, civil procedures. We can see this in our justice system. You think of a system that you see actively, that's active in your everyday life. It can impact someone's health. And we'll go into some examples here, such as education, access, and quality. So luckily, Serena Williams, well-educated, she had great access to health care, but the quality dipped a little there because they dismissed her concerns. She lived in a great neighborhood, was at an esteemed hospital, She had good social support. She's well respected and loved. And she had significant economic stability as a millionaire. So just think about all that in the young teen mom who has been kicked out of her home that doesn't have any of this, didn't finish education, doesn't know where the nearest clinic is, or maybe only gets her care where? From seeing someone like me in the ER. I am not the best spot to get your OB care. I am there, I can handle an acute delivery. I can tell you, no, not today, or, oh, you are over 20 weeks, you can go upstairs. I do like saying that a lot. So the past is prologue. The history we were not taught in school lies at the root of contemporary health inequities. And I'm going to go through a slide that's going to look very busy, but I bet there will be some laws there that you never knew that our government created, and the purpose of creating it was not to improve our nation. It was really to subjugate another group and reduce their access to land, quality of care, education, and even more. So, inequity was hardwired into America's legislative and policy landscape, particularly our healthcare system. So what I'd like people to kind of look at here, we have slave codes back all the way to the 1600s. As I said, 1910, we had the Flexner Report. This is what led to the closure of black hospitals and medical schools in the segregated South. We have the Immigration Restriction Act. We have the Homeowners Loan Act. That's the beginning of redlining. We actually have had multiple attempts to have universal health care. But do we know a reason why we often stymie it? It's not so much because of capitalism. Because if you have health care for all, who does that include? People of color. People that they are trying to legislate from not having equality. So, our government has been involved in this for quite some time. We have had some success in trying to create another policy to remove, such as like the Civil Rights Act, where we tried to get things a little bit normal, but even that, we're saying we no longer need aspects of it anymore because we have equality under civil rights, which we know is not true. So let's bring it to our topic today, and I know I'm running short on time, I'll try to go quickly here. How institutional and structural racism raise stillbirth risks. So one thing we have to think about is Black, American Indian, and Alaskan Native birthing people are more likely to deliver at lower quality hospitals. The site of care explains a meaningful share of adverse outcomes. So unequal access to high reliably obstetric units. This leads to what I don't use as often, but obstetric racism, which can create harmful care delays. So that's your demissed symptoms, delayed evaluation, for decreased fetal movement, and biased triage. Then we have structural conditions. So this is your segregation of neighborhoods, and this correlates with still higher stillbirth risk and widens that black-white gap. And this mechanism includes care deserts, cumulative stress, and environmental exposure. So this is, why, there's another reason why climate change is important, right? Because extreme heat, air pollution, poor quality drinking water, that also factors into fetal mortality. If you can't have clean drinking water, you can't trust the food you eat, you can't trust the air you breathe, that's not gonna do great things for your baby in utero. These are things that can be addressed through policy changes, but often sometimes is ignored. And I just thought, before I go into my next slide here, common health conditions of concern in the Black community. And I'm gonna focus mostly on heart disease and high blood pressure, because that often has the biggest effect with birthing mothers. So heart disease, still very much #1 killer of Americans. The rate of disease has been decreasing due to medications and the American Heart Association, and always just keep lowering a little bit more what is considered somebody that's hypertensive. Everybody remembers the 140 over 90 days. We're like, oh, I'm not gonna get near that. And now half of you in the room are like, darn, I just hit 30. How am I already gonna have to get started on a pill? So, black Americans don't necessarily have more heart disease, but are more likely to die from heart disease due to a delay in care, those deserts, its difficulty of even EMS access to their neighborhoods, or a lack of preventing the progression of disease. So, sometimes many people don't realize that African Americans aged 18 to 49 are twice more likely to die of heart disease than other Americans. And the ACA, which has actually come up in the news quite a bit over the last 10 days, to address this disparity. Hypertension, biggest risk factor for heart disease. 1/3 of black Americans suffer from hypertension. Actually, when you get to black adults, it pretty much goes to 50%. So if you're in a room with black adult, pretty much black folks, I would pretty much say if you're over 40, 50% chance they have hypertension, and they may not even know it. Which then, if you have uncontrolled hypertension, not only increases your risk of heart disease, but also stroke. Many black Americans will develop hypertension early in life and thus goes undetected for many years. I took care of a UPS driver, great family man, and when I used to work in West Virginia. And he came in with left-sided hemiparesis, and it was rather acute. I tried to clot bust him. We were too far away from sending him to a tertiary care facility. He was admitted for a while, eventually transferred him out through rehab. But he didn't have a college degree, but he was the main breadwinner in the home. He, like I said, was only 42 years old, had 2 kids. Wife had a job at a bank as a teller, but so much became impacted and he hadn't been to the doctor in 3 years. So he had uncontrolled hypertension that predisposed him to an early stroke in his 40s, led to losing his job, waiting years to get on disability, ended up hampering his marriage quite a bit. Kids made it very difficult for them to be able to leave that area to go on to college. And you can see the bigger effect just from not controlling one's blood pressure, say for a black community leader, or just for several black men in the neighborhood, that can lead to increased morbidity and mortality that can further make it harder for a community to do well. So, comorbidities are not destiny though. All right, we are not defined, even though I just gave all that information about how this disproportionately heart disease and hypertension is more prevalent in the black community. Hypertension disorders, diabetes, and growth restriction contribute, however, but the disparity persists after you adjust for that. So this implicates the care pathways and racial bias more than biology. So that's what I want you to take away from that. Yes, it's more common in black Americans, but when you adjust for that, where they live, that's the Serena Williams, right? They're still likely to end up succumbing more to racial bias and a care pathway that's impacting their healthcare outcome. So, what good care looks like and where bias creeps in. So we have evidence-based prevention and surveillance. I'm sure many here are familiar with low-dose aspirin for those that are preeclamptic. Particularly if they're at risk for preeclampsia, starting that earlier is better. Starting off in 12 to 28 weeks, ideally less than 16. The key is to ensure equitable identification and offering of low-dose aspirin. And some of these risks being rigorous response to decreased fetal movement. When I ever saw fetal movement in the ED, I am not sitting around waiting to get a confirmatory ultrasound. I'm calling an OB immediately and probably skipping over the OB. I'm like, who's the MFM on call? But I have seen this a bit more because I practice a lot in critical access facilities, right? So I take care of those that are below the poverty line. Quite a few Native Americans from northern Arizona to Wisconsin, to other parts of West Virginia. These are often in care deserts. So not my first time, but I know how to react. Bigger, larger institutions, they may not have a protocol set up if you are able to see something, a woman coming in with decreased fetal movement, or they clearly don't want to say stillbirth because they don't want to scare someone, or a concern for a future stillborn. But antenatal testing, growth surveillance for those indicated risks. Failure points, under referral to MFM. I want to give our MFM more work to do. They get paid well. Late or missed testing, and unequal counseling and induction planning when they're near term. This often tracks with hospital quality and a part of a cause of this is implicit bias, not offering everyone the same care. So, solutions that move rates now. Publish stratified perinatal dashboards, but I think we stopped doing that in the state, right? Because we don't need to show how healthcare birth and healthcare outcomes for women of color are doing. I think also at the CDC, they're going to stop reporting it eventually. So we're going to be relying on other sources on collecting that much of that data, because that's seen as divisive, right? Not addressing the problem. And route Black and Alaskan Native and American Indian patients to higher quality L&D units when feasible, and deploy equity huddles for abnormal fetal testing. Doesn't necessarily need to be done at the floor level, but it really needs to be done by department chairs. And they need to possibly be a section of a M&M that someone's having, where they actually address, was equity in care performed here? And then use standard decreased fetal movement protocols. Clinical practice, recognizing social determinants of health screening with warm handoffs. I see that done at several institutions I practice at, where the nurse is actually doing a social determinants of health assessment. Often we as insurance plans will partake in this as well. Equitable aspirin and screening and uptake, and timely, like as I said, MFM referral, and shared decision-making on timing of birth. So what can we do to increase marginalized communities to trust the medical system? So of course here, we have a lot of reasons for why African Americans don't trust the medical system. Mistrust goes well beyond Tuskegee. A lot of people like to reference Tuskegee syphilis and not treating black men with syphilis in Tennessee. But we had Marion Sims, but also unethical medical research towards African American children as recent as the 1990s. I can give you that reference later. People probably didn't think it went that far forward. Unethical, all right? And good thing that we have some ethics committees that are part of many institutional boards. And then the codification of racism through Jim Crow eras that persisted into the late 1980s. So, trust is vital. Foundational element to therapeutic doctor-patient relationship. Without trust, the patient decision to seek help early or seek preventative care will only diminish. And patient satisfaction supports the notion that fear of race-based discrimination, this is once again, fear of interpersonalized racism, will be impacted or possibly met if they seek care from their local clinic. What we want to do is we want to try to turn around what we can to build trust in the community. So part of it is by practicing anti-racism. That is educating yourself. This is part of the education today, but it shouldn't stop today, and it shouldn't start again in February next year, right? It doesn't just go away for a little while and come back every few months. It's systemic. It's been here for a while. Our foundation is on it. So educate oneself on cultural rules and norms, I often say. Even I need to do this, especially because I've done some cultural faux pas with Southeast Asian communities and Native American communities that I had to learn. And someone corrected me on that. Didn't embarrass me in front of the patient, but they pulled me aside later when I was in the nurse room. So you can't, that's very judgmental what you said there about their cultural beliefs. So we are the Sioux people. This is how we take care of our elders. Please be respectful. We didn't expect you necessarily to know that, but if you're going to take care of our folks, read up on us. Humanity. Seeking humanity in others is at the heart of racism. So we need to make sure we are humanizing. There's some dehumanization that's going on right now that unfortunately we're getting bombarded with a lot in social media, right? Definitely some people many times can say the dehumanization of immigrants in our nation and people of color is occurring with some of these unlawful arrests. And then allyship. That's what I'm doing here today. And I want many of you here to take away this. Take on the struggle as if it's your own and commit to taking risk. And the key here, because I'm doing this as well, trying to bring up the next generation of black doctors, I have to share privilege and access. People in this room that have privilege and access, part of anti-racism is sharing it. And then improve, what can we do to improve patient-provider relationships? treat patients as experts. This is a tricky point because we don't want someone coming in with their chat GPT or Copilot readout to tell us what we should do today. But listen to them, say, all right, yeah, let me hear that. Okay, it makes some good points, but how about we use this plan, all right? It still brings in some aspects of shared decision making, but makes it so that the patient's making the decision and not the AI. Choose empathy, not arguments. Remember, some people want to see you. Most people don't want to see me, all right? No one wants to say, hey, I want to go to the ER today. There are some people like that if they have maybe a substance use disorder, but most people don't want to see me. And I know that. There's fear and anxiety. That's 50% of what I treat. Build a relationship outside of the exam room. If you're in a close-knit community, such as some of these critical access facilities I work at, this can be done, but not always expected. But becoming a healthcare provider that's a community leader, that can help. Because I practice in Arizona and Minnesota. I don't practice in Utah, but people come to me to seek medical advice regularly because I put myself out there educating Black and marginalized groups on how they can take better care of themselves or advocate for their provider to do their job to take care of them. And be a part of the institutional change. Ways to increase trust, attend affordability and access, address affordability and access barriers, safe, welcoming, warm environments, and signal a commitment to improving patient experiences. What have we done to address some of these inequities? We need for cultural sensitivity, need systemic reform. So in your institution, hopefully there's a reform board. If someone has at least asked the question, do we have any practices that, or systemic practices that disproportionately that lead to poor outcomes for those that are from a marginalized background, maybe we should look into that. And then addressing systemic racism. Once again, I said a holistic report, addressing our curriculum. Educating our future healthcare providers is key to this, because when it's happening by the time they're attending, I don't want to say it's too late, but when they're out of training, and which means it's some of this bias is ingrained as they've gone along. And if they're hearing it from me in their 40s, they're like, oh wow, I did all that. I didn't know I did that. So it needs to start so much earlier because it's committed by residents. I see it. Yes.
Sorry.
Yes.
Do you mind going back one slide so we get a picture real quick on the building trust one? Yeah.
That one?
Yeah. Thank you.
Oh, that makes me feel good. I put something good there. All right. Did you get it?
Yes.
All
Thank
right.
you very much.
But I want to get time for questions. So one thing that I do want to bring up is the ACA. As much as it was voted to be defunded and dismantled, it still exists. The ACA and its expansion actually it was one of the biggest legislative policy changes that occurred in our nation to try and reduce this gap in care. It increased access to health care since 2013. It's been stalled. They're doing their best to erode it. I think they voted 45 times to try and do away with it, but nothing to replace it. I think 20 million people now gained access to health care because of this. But the gap between Black and white adult uninsured rates dropped by 4 percentage points, while the difference between Hispanic and white fell by 9.4 points. But disparities narrowed in both states that expanded Medicaid eligibility. Utah took a little while to do that. I think it was, 16, 17 when they finally accepted it. And in those that did not, which we know are certain states in the Southeast and the Southwest, all three groups had better overall access to care than they did in non-expansion states. So what I mostly want to see here is how, when we kicked off with the ACA, people had they were more likely to be insured, and they have greater access to care. Black adults living in expansion states are now less likely to be uninsured when white adults, compared to white adults in non-expansion states. So that's pretty significant, which will, in a matter of time, improve healthcare outcomes. However, there are still forces that don't like equity, unfortunately, in our institutions. So my call to action, if place and bias predict stillbirth, then changing place and practice must be our intervention. Commit to tracking, standardizing, and moving patients to excellence, not asking patients to out-navigate in equity. Because that's often what we say, well, you can do better. Here's a couple forms, here's a handout. Go to this address, this clinic will probably see you. That's all I can do. This is BPOU. It's October, so if you have not scheduled to get your mammogram or getting your annual exam or performing self-breast exams, I highly encourage that. All right, thank you.
We would love to take a few questions for Dr. Ferguson.
Ooh,
Please raise your
random.
hand. Ashley.
So you talked about the mistrust within just general medical care, but there's also a lot of mistrust within research for not only Black women, just the Black community in general.
Mm-hmm.
Do you have any specific suggestions for talking to people about research? Because I know that when I read a research study, the likelihood that there's someone that looks like me in that study is extremely low.
Yeah, so this is actually a great point. So I've worked, are people familiar with the Utah chapter, Delta Sigma Theta? It's a historical Black sorority. So some of their leaders have reached out to BPOU and we've partnered. One of them is a researcher, I want to say with Huntsman, and they realize, and I've realized as well, you need at least one person that's a community leader that you're trying to do, if you're trying to do a clinical trial or trying to recruit more African Americans or someone from marginalized groups in that clinical trial, getting someone from that particular community to be part of the trial. Either trained as coordinator to assist in recruitment, but they need a little buy-in because well, what are you doing with my information and data? So I think that's probably the biggest thing that I would tell a larger institution is have someone, they don't necessarily need to look like them, that does help to gain that trust or at least to access the community. But if someone says, well, I want to be able to do a study within Salt Lake County to see if those that are in Kearns and West Valley and Harriman, if their air quality is impacting their blood pressure. Well, how are you going to try and reach those communities of color in those areas if you're a Huntsman Institute or University of Utah researcher? You're probably going to need the assistance of a provider in the community that has access to where many of those people will meet, congregate, pray, worship. That's how you often will start and say, hey, I want you to be part of our advisor to our clinical trial. So it's I know better. Why would I ask someone that isn't a healthcare professional? But you need to bring them in or else you're going to be shut down. So that's one way to do it. And possibly having a small stipend or, studies shouldn't be free when people are taking blood and, possibly giving them medication. And there needs to be if something doesn't go well, they need some type of assurance that if I have a bad outcome, what's my recourse? So knowing recourse, having someone that represents the community that can be an advisor as you are trying to tell them about a research study. That's what I would say. Good question. Yes?
One of the solutions that you suggested was referring to better quality hospitals.
Mm.
And it occurred to me that, in a lot of my transfers, I might transfer someone to a hospital or refer them to a hospital that all of my experiences have been positive. Are there ways that we know how hospitals are doing as far as equity work, or that I can maybe front load, or say maybe we should go to this other hospital that's done some more work?
So I'm trying to think of the reporting right now. Of course, when someone that credentials hospitals or brings hospitals as the payer, we use CMS and a star rating. That's what we use, and for quality of care. So if we get enough grievances at a hospital where someone's complained about mistreatment that appears to imply racial bias, sometimes it doesn't get that granular. They just look at this person had a worse healthcare outcome and race is never identified. But we can tell if they're just bad outcomes, period, but we're often the qualitative reporting either has to start at that institution if they think they're doing something wrong or if they want to do better, as opposed to waiting for the federal government to receive complaints and give a rating to an institution, which is how things work right now. So I would say NCQA reporting and CMS to get quality metrics for a hospital or a clinic. That's about all you can really do at this time, unless that institute, because I don't know of a nationalized reporting system that will address, that measures health inequities for particular communities that may go to that hospital. It's just outcomes, period, for that hospital.
You said one of those was CMS, and what was the other one?
NCQA, they have ratings, star ratings for hospitals and clinics, mostly hospitals.
We'll take one more question, sorry. We can't keep Dr. Ferguson here all day. Anybody else have a question?
Thank you for your presentation, your work and your service. I was wondering if there's anything that you saw, that you've seen in your work as a serviceman that you wish was actually applied, providing care in that setting versus in the academic setting. Is there any best practices you see over there that you wish were replicated?
Yeah, I have to say the best thing I liked about when I was practicing overseas, taking care of families and service members, particularly outside the U.S., but it happens in the U.S. as well, is often who I reported to was not a doctor. It was another serviceman, often a colonel or general, but usually a colonel. And they said, whatever you can do to maintain morale, keep our families healthy, and keep our soldiers safe and healthy as well, and to retain our fighting force, I will cover it. So I didn't have to deal with prior auths. They just trusted that I knew, and they weren't worried about costs of care. Mind you, when you think about the DoD budget, do you think it's aircraft carriers and submarines and bullets and fuel? That's a big part of the DoD budget. Why would the DoD budget be different than what our largest debts are in our own nation and what we spend on? It's healthcare. But I would say the fact that I was able to provide adequate care is I wasn't questioned about waste and if I was doing the right thing. Now, if I ordered an MRI on every soldier that bummed their knee, someone would probably flag that and go, all right, he's still walking, and did you use your Ottawa rules? Like, it was kind of strange. But my colonel, I didn't have another doctor questioning me. It was often someone that was, let's just call it an administrative leader, is who I had to go through. And they didn't have a medical background, but they trusted their doctor that was taking care of because I often took care of anywhere between 1,000 to 5,000 soldiers I was responsible for. And we had a lot of protocols, and that Intermountain loves. I don't know if the EU loves them as much, but there's a ton of protocols that we followed a lot that experienced physicians would integrate into this socialized healthcare system, which is the military medicine that I'm a product of. So it often worked very well. Anyway, great question. Well, thank you, everyone. I enjoyed myself. I hope you enjoyed it.